Hello. All right. Happy afternoon. It's just after 2:30. I apologize for losing track of time. But we are going to go ahead and get this afternoon started. Please welcome Dr. Richard Gilroy.
Thanks, everyone. I'm going to take you probably an extension from Dr. Feinstein's talk in a direction where you probably haven't been, but a lot of this is not going to be talking about aspects of medical care. And the reason I'm going to be talking about is aspects of operational care, how we develop programs and why we develop programs and what the ultimate good is generated by doing that. So I have these disclosures, none are relevant to the presentation. So when we look at the world, and this is a map of where transplants occur, in particular liver transplants in this case, and when you have a look at the variation in transplant rates, it's enormous. In particular, if you actually look at Africa, for instance, there's barely any transplants done there, and if they are, they're very, very limited, so those pink countries there. But in places like Australia, you have transplant rates that are a fraction of the transplant rates of the United States, and the United States is the world leader in transplantation, having the highest transplant rate from deceased donors in the world. Now, we're not the biggest living donor liver transplant program by any means. We probably give the greatest number of lectures in that domain, because the programs here, the leaders of those living donor programs lecture everywhere. But by contrast, places like Korea and Japan, where they do not have brain death laws that allow for living donor rates, in one center in Korea, they do more living donor transplants than the entire country of the United States. Now, with everything, there are wars. And we've got an unfortunate war that's going on right now in Russia, and with different parties getting involved in that. Again, we have the Israel and Hamas war. We also have the situation in Sudan, which is another terrible tragedy that continues to go on, and most of this is all driven around wealth, power, and usually a political struggle. And liver transplant, and that title is actually taken from there was another reference paper from the New York Times that talks about the liver wars. And they occurred, and they were quite significant, and they led to some changes. And people think that transplant equity still exists. I'm going to show you why it doesn't. And I'm going to explain to you it's got nothing to do with policies at a federal level, but everything to do with program performance. So the objective today, I'm going to talk about the environment, including the politics of organ transplantation. I'm going to talk about inequities and why they exist. I'm going to give a little bit of an explanation about organ supply, where organs come from, how those organs are used by various groups, and then we're going to talk about what our actions do to influence whether or not people within our populations are served. And I'm going to give you actual true case examples of certain state-level transplant rates and how they're impacted by programs. And finally, I'm going to ask people in the room if they have ideas about what they're choosing to develop. I'm happy to give any advice on how I might consider approaching that problem. So, I made reference to politics, and this is why it's so important. So this is an article from the New York Times. Transplant is appropriately the most regulated domain in medicine, and it is also the most scrutinized. So anything about me and my program you can identify on publicly available websites, from how many transplants we do, how well we do when we do those transplants, the type of organs that we take for those transplants, whether or not a patient is alive 1 year after a transplant or 30 days after a transplant, whether or not we've been cited for making mistakes. It's all publicly available records, and it is appropriate because it drove quality. The outcomes for a transplant went from 86% 1 year survival to currently 94% 1 year survival after a liver transplant in the US, all because we started reporting. So, to the previous speaker, I say that we must be doing this. It's not that we should be thinking about doing this. So we talk about this one, a Pennsylvania program. This was last week being closed. And then we go to another one, a Texas program, and if people read the Washington Post or the New York Times, they will have read about this case that involved the Memorial Herriman Hospital in Texas, and this surgeon and what he actually did to influence whether or not people on the wait list lived or died. However, this isn't isolated. There was another program in Texas, in the medical city in Texas, that was closed, and had the FBI in doing fraud reviews. So transplantation is a dangerous domain, and my career as a physician could be ended pretty quickly, just like, unfortunately, Dr. Bunyan's. So why do we do this, and why the problems exist? One, profits. In non-Medicare transplants, they bring substantial institutional revenue. Two, profile. You get public recognition, you get advertising value equivalence, meaning that if I put a child on TV who's had a liver transplant, people will remember my institution. Now, most individuals in Utah, when I say I do liver transplant, believe, I'd say 9 out of 10 individuals would ask or state that I work at the University of Utah, where I've never worked, but I have patients often referred there with my name on it. And the reason is because they have the recognition as being a premier academic medical center, and they may well be deservedly so. I'll present other data about that later. The other thing is, the reason I do it is service, because I am allowed to be associated with a life-altering procedure. And then finally, competition. So when we look at this thing called the final rule, this is what we all fight over. And it creates all this thing. And what everyone thinks is that everyone should have the same organs equally distributed around the country. But 0.5 says you've got to avoid wasting organs. So if you fly them further, they're more likely to waste or get lost, which happened on a UPS flight not too long ago, again in the news. The other one is patient access. If you fly them all around the place and you're in an under-resourced community like Mississippi, then the difficult part is your patients see less office because other people come and take them from the larger cities that are around you. And then finally, it's to promote efficient placement, and that doesn't include increasing transport costs. And currently, the new transport costs went up by $90,000 because of a new technology that allows us to transplant about 1,000 more organs a year. So we have all these rules that came out before and after allocation. MELD came in to try to make the playing field equal, and then we've made all these modifications along the way. So you'll see all those different rules there, and I'm going to show you maps of what happened after those rules occur in terms of equity. And one inequity issue we have failed to address until reportedly recently is that associated with the female sex. When they went to MELD, less women were transplanted and more women died on the wait list. The national committees said, hey, you know, we need to do something about this. And after 23 years, they actually did something, but they had published data not only in 2011 and 2004, illustrating that women were disadvantaged by the system. And part of the reason that they claimed they wouldn't do this is because they wouldn't direct small livers to small women, because they felt that that was unfair. But the problem is women can't take big livers, so they were disadvantaged for an extended interval of time, and I've published in this domain. But there are ways to operationally, and I stress the word operationally, address this. And this is what we have in terms of our transplant numbers at Intermountain, 39 transplants in 2018. Last year we did 182 transplants. And for the female sex in the living donor domain, the majority of the living donors go to women. And by doing that, we address a disparity. So again, the inequities, we are in region 5. We had the highest death rates from liver disease in this region when you go back to the beginning, or at least prior to MELD. And we also had the highest costs because MELD predicts cost. So the big issue for us was that we needed to change the rules, and we did that. Now, when you do this, then you create disparities, and this is what happened to the US veterans system. Now vets can be transplanted at any place in the country, but when MELD came out, there were 4 transplant centers in the country that could transplant vets, and they couldn't get there, so they had the higher waitlist mortality. Again, something we could have addressed operationally, and national committees knew about, but the politics of transplant were, they were concerned that that center might do more transplants, which is wrong. So again, transplant center performance determines disparity. The Veterans Affairs hospitals were underfunded and under-resourced to be able to do what you need to do. But market performance is the effectiveness of a business, in this case, for me as a transplant doctor, to utilize the economic resources available to me, which are organs and accessing patients, to maximize benefit to consumers, which is transplanting those people with end-stage liver disease. Now, we do that by enhancing our operational performance, meaning how we actually perform what we do. To change a program, you have to change operational performance. To change operational performance, you have to get investment within your institution and an allowance for change. And that can be the greatest barrier to transplanting more people in your state. And so when we have a look at it, and these again are looking at data that looks, and you see their Indiana health systems. In 1998, they did 18 liver transplants at University of Indiana. They were a new program into the market, and then they introduced a new system. And if you look at the state of Indiana, and again, I'm Australian, I'm not supposed to know which one it is, but I do know it's next to Illinois. But you'll see it went from a darkish sort of brown colour to a bright green colour, going from the lowest transplant rates to the highest transplant rates in that study. And this is the first evidence that an organization's operational performance can change whether or not people in that state live or die with end-stage liver disease. So again, when you look at the state resident transplants in that state, they went from 10 to 60. That's 50 additional lives that are saved by transplantation by simply coming up with a better operational performance model. When we look at transplants versus listing, if you don't list people, in this map, the left-hand side is listings per million, the right-hand side is transplant rates per million, and the average for per million adults, that's the per million adult figure, is 48.8. If you look at Idaho, where you have very high listing rates now in 2023, you'll also see Idaho doesn't have a transplant program, but has some of the highest transplant rates in the entire country. And we'll talk a little bit about why that occurs. But in general, if you increase your listings, you'll generally transplant more people, with one exception. And I'll draw your attention a little bit later on to the state of Arizona. So again, we see listing rates. This is 2016 data as compared to 2023 data for listing rates for state residents. And I'll draw your attention to the state you know, which is Utah. And you'll see that it's actually gone from a brown color, which means that we're listing less than average, to a blue color. And then you'll see Idaho, smaller population, goes to a darker blue color. And why did that happen is because, again, we'll talk about operational performance, but the most competitive markets in the country actually lead to the highest transplant rate, and that would be Maryland, where you've got University of Maryland and you've got Hopkins, and in each other's back door, you have a dense population, and consistently, for the last 15 years, they've had the highest transplant rates in the country, with one exception. For 3 years, the University of Maryland's, Johns Hopkins University went under a system improvement agreement, meaning that their outcomes were bad enough that they had to reduce the number of transplants, and it cost them $10 million to dig themselves out of that hole because they forgot about quality. So quality is tied into transplant. We're publicly reported. Payers determine whether or not they will pay for a transplant at our centre based on our performance, and you get removed from a payer's schedule based on data that comes out every 6 months. And if you have 2 consecutive reads, then they'll renegotiate your contract. So when we look at factors that sort of impact a program's performance, one thing about Utah that makes it a bit more challenging in Idaho is distance. And distance from a transplant center predicts your likelihood of dying on a wait list. But a distance from a transplant center also predicts the likelihood of those resources in your community being available to keep you alive when you're sick, whether they're there or not. In other words, a hospital that may be in Las Vegas, Nevada, will not provide equivalent care to a hospital here in Ogden. And that is because the hospitals here in Ogden and the healthcare delivery system in Utah delivers in the top 5 for states within the United States in terms of overall healthcare delivery, and Nevada comes in at number 48. And there's only 50 states in the US, so it's not very high. But it creates these barriers and operational challenges. Most systems set up what's called a hub and spoke, but if you have a hub to very weak spoke points, like Nevada, then you're likely to lose people after transplant or before transplant, which will count against your program, and that actually can lead to loss of contracts and even closing your program. So it's a very difficult area we work in, but everyone's fighting over organs because transplants of insured patients generate revenues for institutions, or at the University of Kansas, when I left there, about 26% of their bottom line. So let's look at a few states for examples. The first one here, this is Ohio that you can see highlighted with the arrow. In the state of Ohio in 2019, there were 425 liver transplants that occurred, and then 2023, 600. And a few things happened. Number one, they started taking types of organs they didn't take before. This is called donation after cardiac death. We can thank the Sackler family for this, because the Sackler family introduced a drug called heroin, or at least they brought in OxyContin. OxyContin then led to the fentanyl heroin pandemic actually being amplified. And then what we've seen as a consequence of this is more people who get injuries, but not deaths, that are associated with needing to basically withdraw life support for their heart to stop. And then after their heart stopped for 5 minutes, then we can procure organs, family and individual consent permitting. But we are able to now use more of these, and as you can see, one center there, 40% of the organs that they get come from that process, as compared to 6.6% that occurred at Cleveland Clinic, initially at least when they started. The other thing they did was they took what are called marginal offers. So ODE means observed versus expected acceptance of an offer. And if you're coming in at a high number, and this is the University of Cincinnati, they take more marginal offers than any other program in the country currently, bar one. Actually, it's now bar two. And one's Intermountain, the other one is the Mayo Clinic in Arizona. That 2.24 means that you take donors that at least the vast 2 standard deviations of programs have excluded from that offer. And they do that with excellent outcomes, 94% 1-year survival. So competition here, I would petition, drives change. When we look at a different state, which is Oklahoma, and what happens here is that 2 programs co-develop and they drive each other's listing numbers up, and then they change the type of organs that they accept. That meant that they had growth. So Oklahoma goes dark green, and you'll see Kansas, the state that I was at previously, has gone pale white. Now, politics, and this is always good, and Senator Moran I actually know, but this drove a very important conflict. It was featured in the Washington Post, and new rules reduced the number of transplants that occurred in poorer states, which was kind of true, but poorer states were under-resourced, they had diminished operational performance, and the true confounding bias is the real reason that there was a reduction in transplant is because they were not ready for the new rules and able to adapt quickly. And as you can see, when you do this, and this is where the politics come into it, this is Jerry Moran's page for his own personal page, and this is one of the points that he drives home with the voters as to why he's someone who should be considered. He's changing politics, and he's using organ transplantation as part of the vehicle for that. Now, when we look at Kansas, you can see that it had a rapid rise in the number of people it was listing, and it increased its number of transplants. And last year, they went from 114 in 2013 down to 51. As compared to the national average, all programs increased by 25%. So if you decrease by over 50 or greater than 50% reduction, that's compared to every other program that by effectively a rising tide, everyone else was doing 20% more. So this performance is not good, but their observed to expected rate is 0.71, and then the other part of their DCD is 2% rather than 17%, which is the national average. So they chose their position. It wasn't a question of a new law. So the other part is when we had a look at Ochsner, the real reason there is that Ochsner got pummeled a bit by Katrina, but the second part to Ochsner is that they had a change in leadership. and the number of people that they listed diminished, and the number of transplants they did diminished. They were the largest program in the United States in 2018, and now they're about number 50. And then we look at Mayo, Arizona, and this is the most important interaction. Mayo, Arizona is a very commercial enterprise. In 2018, the map on the left-hand side, 70% of the people that they listed were within that state. They developed a contract with Kaiser Permanente. Kaiser now sends 120 people to be transplanted in Arizona by Mayo Clinic, and there's organ offers around Arizona that can be utilized. That leads to a reduction in the total number of Arizona residents who receive a transplant. And Banner Phoenix, which does predominantly 98% local, is now in a situation where, because of the pressure of Mayo Clinic and the politics associated with the economic models of both institutions, now has a reduction in the number of locals it can transplant, so locals suffer because Mayo gets bigger. As to where we are today, this is the story of Idaho and Utah. We went from 39 transplants to 182 transplants. We increased substantially the number of non-residents in Idaho, so we went from 3 last year to 53, and that led to a total number, or increase in total number of transplants of substantial, as compared to the University of Utah, which is static right now, and unfortunately, in the quality domain, they have some challenges ahead of them because they've dropped below predicted. So I'll skip over this, but I'll just sort of get to some important ones. This is Stanford University, and one way to transplant more people is to transplant more people for alcohol. So they went from 24% when they listed 171 to listing 162 and 51 transplants, and their total transplants nearly tripled because alcoholic hepatitis gets a high score. Now, is that the right thing to do? Probably not. University went from 22 to 46%, and Intermountain went from 24 to 30%, all publicly available and verifiable data. But what do we have to preserve is quality. So we have an observed versus expected transplant rate. We're better than where we should, would be predicted to be. That's terribly important. In terms of receiving a deceased donor, you're more likely to get one with our program. If you look at the number of grafts that fail, we do better than what is expected of us, which means more grafts stay alive, and we have fewer patient deaths. So when we have that, we get preferred contracting, but we also have the ability to develop. So quality drives the ability to develop is the principle. And why do we want this? Because the public cares about it, payers measure you by it, and most importantly, if you have this backbone, then you can bring the right people. So the best people will go to the best performing players. So we have been able to recruit great people now after we've gotten to these numbers in the last 2 years. So Nevada is the market that we've been looking at. Idaho, Utah, Montana, Arizona, and Nevada are all markets with growth. And we look at the distribution. Nevada has 3.2 million people and no liver transplant program. Predicted rate for transplant should be 120 individuals in that state. And that's just if it goes close to national averages, but they have a high prevalence of liver disease, so it should be higher. These are all the different centers that have transplanted out of Nevada. As you can see, there are a lot. And in terms of it, from our perspective, we've now placed a program there, and the institution bought Intermountain, or Healthcare Partners, now Intermountain Nevada. And this is sort of what happens for us. We went from listing around 70 people, and we are listing 140 now locally, because we've identified how to get people into the system and to help them, versus we used to have a wait time to get in to see us of 3 months. A lot of people would die before they got to us. The second part of Nevada is that only 80 people out of 3.2 million people actually get access to a waiting list, let alone only 60 people get a transplant compared to 117 here with populations of comparable size. And we can work out how to do this, and anyone can work out how to do this by going to these resources to tell you where a need exists. And when we look at Nevada specifically, you can see an enormous gap. So SWOT analyses I won't go through anymore, but bottom line is you need to look at markets. And just remember that other people look at markets as well. So USC Keck just announced this last week, the week before. And this is where they placed their program relative to our program. And I'd point out that that's actually Nevada and Las Vegas, and we are 6 minutes or 15 minutes walk away from each other. And they're the only two programs in town, which doesn't seem to make a lot of sense. And sometimes for me, it's a bit like this. You feel like you're this guy paddling, trying to push around a very large ship. And Intermountain's a very large ship. We're a small profile. But you always remember underneath it is this iceberg that if you hit it and run aground, there's various things that can happen, including your career can be decimated. So for our institution, the most important thing is, for us in Las Vegas, it's a tipping point, right? And we are dealing with an underperforming medical system, and we're trying to deliver a very complex type of process, and we've got to work out how we do this, and what we have to remember, if we don't, someone else will eventually work it out. But you never want to ask who moved my cheese. So these are the types of changes that we see happen with our program. We went from 71st in the country in terms of transplant volumes to being number 9 now. That places us greater than Mount Sinai in New York. It makes us equivalent to UCLA in terms of volume and UCSF, and smaller than Mayo, Arizona. And the things you need to understand is, to be successful, you need a high-value network of individuals and providers. You've got to get buy-in from everyone. You've got to look at local hospitals, and you've got to build into their systems and their EMRs. If we wanted to get bigger, we need to create a national brand. And as I've said before, I'd say 9 in 10 primary care physicians, if I said I was a liver transplant doctor, they would think that I worked at the University of Utah. Develop dashboards. If you can't measure it, you can't manage it. Peter Drucker, great statesman, excellent economist, but he will tell you that that's terribly important. And then finally, you need to build up facilities. But this is the real reason you do it, and this is a lady who has since been transplanted. She had quite a tragic story that led to her end-stage liver disease. That's her daughter on the left, her friend on the right. That's her before transplant. She then gets intubated. She was on presses, and she's in the ICU with decompensated liver disease. This is her 1 day after her transplant. This is her 3 months after transplant. If you worry about the appearance, yes, she is and was a very successful model. But this is another reason I do it. This is an organ that was pumped on a pump from a far facility. Not only was it pumped, it was taken from one of those DCD organs. So pumps are things called normothermic pumps that keep livers alive longer. This is the individual the day afterwards, and she's also my research assistant and soon to be a medical student. This is her 14 days after her liver transplant. And then following that, she did a presentation at the Controversy in Transplant meeting on day 15, meaning that 15 days after her transplant, she flew to an international meeting and gave a presentation on the data that I've just shared with you. But the bottom line is why I also do this is because I get to work with these guys. And these are the transplant surgeons. You'll see Jean Boito on the left. You'll see Alan Contreras is with the cap just to the back of us. And what they're doing there is a living donor transplant. But this is our team, and only teams can develop processes. And I'm happy to take questions.
So one thing that's always confused me is to be higher on the list for a transplant, you need a higher MELD score, right? So in that sense, the sicker the person, the higher they are on the list. But then there's this critical threshold that they pass where if they're too sick, then they're not a candidate. That part, I guess I'm not sure how that's judged or how that's scored, but that's what I've kind of observed. So can you speak to that, that narrow window of being sick enough, high enough MELD score, but not so sick that they're not going to be a transplant candidate?
And you're talking to the point that creates a disparity, right? So if I live in New York City, I've got multiple medical centers, I've got level 1 trauma and everything else. And in those centers, I can keep really sick people alive because I've got all these specialty care things. The break point for whether we can keep them alive or dead is whether or not the predicted survival, and we have models for this, is better than 70%. So if I get a person who's severely malnourished, who can't walk more than 200 meters, who's over the age of 60, who has associated with this condition any degree of cardiac calcification or whatever, that probability drops. If I put them on dialysis and on a pressor in the ICU, they're below 70%. And the reason is because if I get too many hits against my program for mortality, and that percentage dictates what the probability of that hit is, then what happens to my program is the insurance company comes in and says, we're not funding you anymore. The administrator comes in and says, your outcomes have dropped below predicted. What are you going to do about it? And I've got to remember, I'm trying to do the greater good, so I can only treat as many sick people as I can. The issue with the sick people is this is counter to anything we do in medicine. Because in medicine, it's prevent illness and to heal, right? What we actually do is we create a format where we have to have people get sicker, and we have to wait for them to become more malnourished, and we have to wait until they're just about to drop off a cliff because of this MELD priority system. And then we have to catch them if we can and hope they don't fall off the cliff. So the system is counter to anything we do in medicine. So if you came along to me and you said, listen, I've got a MELD score of 15, transplant benefit, can I get a transplant? And you say, I've got a living donor, within 2 weeks I can transplant you because your living donor can be worked up and we would be able to transplant you. But if you've got a MELD of 15 and you're older and you're getting weaker, and your MELD score, which is bilirubin, albumin, INR, sodium, is not going up, then you'll die before you get a transplant. And that's the sad reality of it all, unless you've got a living donor. In Utah, we've got Good Samaritans. Individuals who say, hey, and one of maternal fetal medicine doctors is one of these. She said, I want to give part of my liver to a child. So anonymously she did that. And then 2 years later, she came up and said, I'd like to give my kidney to someone else. And she did that too. Now, I sat there and just said, please don't give up your heart. But the reality is that here in this state and other states like Idaho, which is higher than here, individuals step forward for a living donor liver transplant because that has the same outcomes as a deceased donor, and you don't have to wait. So to address the issue that you have, which is, how do I stop them dropping off a cliff and why do they have to get sicker? Because that sounds stupid. It is stupid that people have to get sicker to get an organ, but people argue that's equity, meaning that if we take just the sickest, which have got the highest mortality, the others can wait to get sick. But if you look at it overall, the best thing is living donation. Sorry for the long answer.
Thank you, Dr. Gilroy. That was wonderful.